So lung cancer, let's understand how it presents. It can present with the patient being symptomatic. You've done a scan for something else, and you find a lung mass as an incidental abnormality. You're screening your patients with low dose CT and can also have paraneoplastic syndromes. When do you suspect a patient to have lung cancer? When you find a lesion which is more than 3 centimeter and it's a new lesion. There is a measurable growth in any nodular mass which was not there previously. There is presence of pleural nodularity, asymmetric or significantly enlarged hilar or paratracheal nodes. A patient may present with an endobronchial lesion, or there is an area of consolidation which appears suspicious. So, lung cancer can have varied presentations. Now, this is an X-ray showing you lung mass in the right mid zone. Then again, a different presentation of a lung mass you can see on both the sides, majorly on the left as well as on the right near the apex. Again, there is a apical left lung mass. There are certain lesions in which you suspect there can be a suspicion of lung cancer as the lesion appears. As you can see here on the X-ray, it appears like a small nodule, and when the scan was done, there's a large speculated mass over here on the coronal cut of the CT of the same patient. Now, the presentation, like I said, can be varied. Patient can have an apical tumor, the Bankos tumors can have a mass with speculated margins. There can be presence of an adenopathy or a hilar opacity, hazy opacities, reticular opacities. There can be presence of lobar collapse, effusion, a malignant effusion, a non-resolving consolidation, invasion and erosion of the ribs, a thick walled cavity. Patient can also have a lobar collapse. So there can be varied presentations on a chest X-ray. Now, what do you see on a CT scan that is suggestive of malignancy? Irregular speculated margins of a mass lesion, thick walled cavitatory lesions, nodules with mixed attenuation, pure ground glass lesions when they are persistent or slowly increasing in size, and then presence of multiple nodules. Again, these are three different CTs, and as you can see, there is a mass lesion which has a part solid and there is a ground glassing. So there are different presentations of lung cancer with pure ground glass lesion or a part solid and part ground glass lesion. So, usually when you measure this part solid and part ground glass, you measure the solid part. That is what tells you about the size of the tumor, basically. And as you can see on this axial cut, there is mass with speculated margins, another irregular mass in the lung. So varied presentations on X-ray as well as CT. Over here, tumors can compress, invade adjacent structures as well. As you can see, the right main bronchus is getting compressed with a mass over here, right lung mass. Then this is invading the vascular structures, eroding the ribs. This is invading the pleura. Then these two are, basically in the mediastinum, involving the mediastinal structures. And similar presentations of, invading the surrounding vascular structures as well as invading the bones, ribs, spinous process. So the spine, basically. So tumors can have different presentations on CT scan as well as chest X-ray. Now you have certain symptoms which are suspicious. So how do you basically diagnostically approach and evaluate a patient with suspected lung cancer? Patient with high suspicion of lung cancer, for example, you have a mass on chest imaging, like in a patient who's a smoker, patient who presents to you with hemoptysis or weight loss. So first, what you do is you obtain basically a contrast enhanced CT scan if it is not already performed. Then you assess the clinical likelihood of metastatic disease based on the following. What that is first, preliminary CT chest radiographic stage, then clinical assessment, then lab findings. Based on this, you basically further decide about the metastatic disease. Then further approach to evaluating a patient is either comprehensive or clinically based. The comprehensive is that after your initial CT, you're suspecting cancer, everything is clinically is also giving you that the patient. So now you have to you perform a PET CT. Now PET CT uh, will actually help you to stage, and not only just stage but also help you to select an optimal site and perform the tissue biopsy. Similarly, if you have a site which is specifically you're thinking, on your clinical suspicion for metastasis, then you specifically image those sites. For example, a patient has neurological symptoms, so you plan for a brain MRI or a spinal cord MRI. Patient may have bone pain. In that case, either X-rays or maybe a PET again might be needed. In case of a pleural or pericardial effusion, you're going to require a thoracocentesis and echo to evaluate for malignant effusions, right? So accordingly, if you have a high suspicion, then you can specifically do a site-directed imaging as well. And then some areas, some places, PET is not easily available. So even in those places, a site directed imaging is a more doable and more approachable. Then of course with these also these imagings help you to select an optimal site to perform the tissue biopsy. So the major limitations of comprehensive and clinical based approaches, that comprehensive is relatively high false positive rates with the PET, lack of standardized criteria for a positive result, and of course PET is whole body PET becomes expensive. Uh, Clinically based, there is a low sensitivity of chest CT for lymph node mets. There is a need for confirmation with tissue sampling. And there is a potential for missing occult disease, which your PET will pick up, which your CT will not. So, especially if you're doing a site specific CT. So, these are the major limitations of each approaches. Now, it is important that you have a suspicion, you have a patient who's presented with clinical symptoms, you've done the appropriate imaging, you've identified that there is a mass lesion. You need to biopsy it to be able to diagnose. And for the biopsy, of course, it is patient centered, it is tailored to individual patient. You have to see the risk versus benefit, what are the patient's preferences, and what is the available expertise at your center. It is important to understand that you need to provide enough material for histopathological, immunohistochemical and molecular assessment. Remember, you need to send your samples for all three. And you should aim to diagnose and stage non-small cell lung cancer with a single procedure or minimal number of invasive procedures if more than one is required. Try and do the sampling when you're doing an invasive procedure within that procedure if possible. Try to keep the invasive procedures to minimum, and try and get maximum sample, provide enough material. Otherwise, your pathologist is asking for more and more sample, and the biopsies are then become inconclusive. So it basically delays your diagnosis for your patient. Now, when do you suspect advanced disease? When there is presence of scalene or supraclavicular node involvement. Um, Choosing the safest and easiest approach for pathological confirmation is preferred for non-small cell. Then if you have a pleural effusion, thoracocentesis should be done. Remember, you need to tap that effusion and you need to send minimum of 50 ml of pleural fluid. It has to be sent for cytology as well. Then, for patients with solid pleural lesions or thickening, a thoracoscopic or image-guided biopsy is necessary to confirm the suspected non-small cell lung cancer. And for those with suspected metastasis to the contralateral lung or extrathoracic organs, the suspected mets should be sampled to confirm the diagnosis and stage rather than the primary tumor, with of course exception of the brain. So remember, when there is contralateral metastasis, you need to sample the suspected metastasis always to confirm the diagnosis for staging as well. Now, you've done the biopsy, you found out the tumor, you need to do the staging, and the accepted staging is the TNM classification. The latest is the 9th edition. And classification, it not just TNM staging, not only helps you to stage, but it also helps you to understand and formulate a treatment plan for your patient. And it also helps in prognostication as well, which is very important. TNM is done for both small cell as well as non-small cell lung cancer. It does not apply to pulmonary sarcomas, lymphomas, and other rare tumors. Now, we all know about the T descriptors, the N descriptors, and the M descriptors. So T is basically a tumor. TX is your tumor, which is diagnosed in sputum, bronchial washings, and it cannot be assessed via imaging or scopy. T0 is no evidence of primary tumor, and TIS is carcinoma in situ. We will look at these descriptors as we go ahead. And like I said, M descriptors, which is your metastasis. It is important. Why is staging important? Like I said, it not only helps you to plan treatment, stage the patient, but it also helps you to prognosticate. As you can see, in stage 1A, the 5-year survival is almost 82%, which reduces to 7% in stage 4B. So it is very this is a very, very important aspect of staging, of the TNM staging of lung cancer. Now we look at the descriptors, the T descriptors, the N and M descriptors. Let's start with the T descriptor, which is your tumor. T stands for your tumor, and it's T1 to T4. So let's look at the T1. T1 is basically a tumor which is less than 3 centimeter in size. It is surrounded by lung or visceral pleura, or in lobar or more peripheral bronchus. Now T1MI is minimally invasive adenocarcinoma. T1A, T1B, and T1C is a different size of less than 3 centimeter, which is T1A is less than 1 centimeter, T1B is more than 1 but less than 2, and T1C is more than 2 but less than 3 centimeter. Now, this is a typical T1 tumor of the left lower lobe, 23 mm, which is basically T1C, and is surrounded by the pulmonary parenchyma, as you can appreciate here on the coronal cut of the CT. Now, T2. T2 is tumor with any of the following features: more than 3 centimeters, but less than 4 centimeters. Okay, so this is a stage one after T1, which is less than 3. Now, this is more, T2 is more than 3, but less than 4. It invades the visceral pleura. It can involve the main bronchus. It can cause atelectasis or obstructive pneumonitis. And it can, so now T2, like I said, has T2A. This is your T2A, which is more than 3 but less than 4. The T2B is a different size. It is more than 4 but less than 5 centimeter. So T2 has two parts, T2A and T2B. T2A is more than 3, less than 4, and T2B is more than 4, less than 5. And of course, even in T2B, you can have the other descriptors, like I said, pleural invasion, involvement of the main bronchus, and atelectasis or obstructive pneumonitis. So this can be even in T2B as well, but the size is more than T2A. So this is a T2 tumor. You can see that there is atelectasis and pneumonitis of the left lower lobe. And this is basically up to the hilum, and this is due to the involvement of the left lower lobe bronchus. Now T3. T3 is again, as we are going ahead in our T descriptors, the size of the tumor is increasing naturally. And of course, there is additional involvement of the structures. So T3 is more than 5 but less than 7 centimeters. Now this invades your azygous vein, phrenic nerve, or even the pericardium. Invasion of the chest wall or thoracic T1, T2 nerve roots or stellate ganglion. This is something new which has come up in the 9th edition. Invasion of the parietal pleura and satellite nodules in the same lobe. Sorry, in the same lobe. So T3 is a tumor with any of the following. Like I said, it's more than 5 but less than 7. Can involve parietal pleura, pericardium, phrenic nerve, azygous vein, thoracic nerve roots, tumor nodules in the same lobe. And direct invasion into the lymph nodes is classified as lymph node involvement. So this is your T3. And this is a T3 tumor in the right upper lobe. It is invading the chest wall. Now T4 is your tumor, which is more than 7 centimeters in size. It can invade into the trachea, the superior vena cava, the great vessels, invasion of carina, invasion of your diaphragm, invasion of subclavian vessels, plexus brachialis, cervical nerve roots, ipsilateral nodules in the different lobe. And it can also invade your esophagus, mediastinum, heart, vagus nerve, recurrent laryngeal nerve, and even the vertebra. So this is your T4. And T4 is more than 7 centimeters. Like I said, it invades various structures: mediastinum, thymus, trachea, carina, recurrent laryngeal nerve, vagus nerve, esophagus, diaphragm. And there are separate nodules in the different ipsilateral lobe in T4. So this is a typical T4 tumor in the right upper lobe, and it's invading the mediastinum. There is invasion of the right pulmonary artery. There is invasion of the carina, and there is also invasion of the left atrium. Now, what are the changes that have occurred in the ninth edition? Not very major changes, but little changes in the categories. So invasion of the adjacent lobe has been added as a T2A category that we just discussed in the T descriptors. Then azygous vein, thoracic nerve roots, and stellate ganglion involvement are added in the T3 category. And the various mediastinal structures and the vertebral bodies, the spinal canal, and the vessels have been added in the specific involvement has been added in the T4 category. So these are the major changes which have occurred in the T descriptors in the ninth edition. Now, this was something which was discussed in the last session. And as you can see, if you have a patient with a Pankos tumor, especially a tumor in the apex, remember sometimes, you cannot appreciate on a CT that there is invasion of the adjacent chest wall or not. So you need an MRI. And because this now has changed the stage. Earlier on the CT, it was appearing only isolated in the apex, as you can see here. But now when you look at the MRI, you see that, there is an invasion of the tumor into the chest wall. It is invading. So this has actually changed your stage of the tumor. It changes the entire treatment plan, and it further also changes, your staging and prognosis as well. So this is something important and you must keep in mind. Now let's look at the end descriptors, which is the regional lymph node classification system. So you all know about the mediastinal nodes. Now, the various stations of the mediastinum as well. Regional lymph node involvement in lung cancer includes your intrathoracic, scalene, and supraclavicular nodes. Remember, there are various uh, different investigations, modalities through which you can approach these tumors. Like you can do EBUS, endobronchial ultrasound, transbronchial needle aspiration that we do as pulmonologists as well, which is for your lymph node stations 1, 4, 7, 10, and 12. Then EUS, that is your esophageal ultrasound. For that, you do your stations 7, 8, and 9. Now, stations 5 and 6 are usually preferred because generally surgeons do it. So it's a generally they are preferred and they are approached through VATS. And even mediastinoscopy can be done. And for mediastinoscopy, you can approach 2, 4, 7, and 10 stations. So different modalities are available. And depending upon your lymph node station, you can use the specific modality to do the biopsy and FNSC of your lymph nodes. Now, when we look at the end descriptors, that is N1 to N3. N1 is basically metastasis in the ipsilateral, intrapulmonary, peribronchial, or hilar lymph nodes. Okay. Then N2. Now, N2 has N2A and N2B. The difference between N2A and N2B is N2A is ipsilateral, mediastinal, and subcarinal lymph nodes. N2B is multiple ipsilateral, mediastinal, and or subcarinal lymph nodes as well. So in N2B, you have multiple ipsilateral, mediastinal, or subcarinal lymph nodes, and in N2A, you have a single ipsilateral, mediastinal, or subcarinal. So difference between a single and a multiple nodes, whether it's on the same mediastinal side or subcarinal lymph node station. And N3 is basically your contralateral, opposite hilar and mediastinal lymph nodes, or even your scalene or supraclavicular nodes. So N3 basically is the contralateral and mediastinal, contralateral, hilar, and mediastinal, as well as scalene and supraclavicular. So as you can see over here, there is a tumor in the right lower lobe, and there is an ipsilateral node involvement. So N1 is your ipsilateral nodes within the lung, and there can be also hilar nodes. sorry, N2 is nodes that represent ipsilateral, mediastinal, and subcarinal. Like I said, N2 is N2A and N2B. So single node station is N2A and multiple node stations is N2B. This is a right-sided tumor, if you can see here, with lymph node metastasis. And it has 4R and 2R mediastinal lymph nodes. So it becomes your multiple lymph node stations. So it's your N2B site. N2B. Now, N3 is contralateral mediastinal or contralateral hilar lymph nodes, and even patient can have scalene or supraclavicular nodes. This is a irresectable disease. This is an irresectable stage. And like you can see here, there is a right-sided tumor with N3 lymph nodes metastasis. It includes the contralateral 4L and 5 station. Two different patients with N3 disease. The lymph nodes are on the masses are on the right and the lymph nodes are on the left side, contralateral side. Different presentations again of a right-sided tumor. It is involving, there are nodes in the para-aortic area, the hilar nodes. They're involving the mediastinum. There are also supraclavicular nodes. So again, an N3 disease. Changes that have occurred in the end descriptors in the regional lymph node staging is that there is subcarinal node. The N2 basically has a single station or subcarinal node involvement. It can be single, that is N2A, and N2B is multiple station involvement. The rationale is because in the N2B has a worse overall prognosis and survival rate as compared to N2A disease. So if a patient has a single node station involvement, that is N2A, the prognosis is better as compared to multiple lymph node stations, which is the N2B disease. Now the M descriptors, which is the metastasis. M0 is no metastasis and M1 is distant metastasis. So in M1, we have M1A, we have M1B, and M1C also has two parts. So M1C1 and M1C2. So M1A is basically your intrathoracic metastatic disease. So we'll just look as we go ahead. So this was your M1A. First, I'll show you M1A. So this is regional metastatic disease, which is defined as a malignant pleural effusion or a pericardial effusion. There can be contralateral tumor nodules. Okay. So your primary tumor is here on the right, and you have contralateral tumor nodules. You can have malignant pleural effusion with pleural nodules, a malignant pericardial effusion with nodules. So this is your M1A disease, which is your regional or intrathoracic metastatic disease. M1B is a single extrathoracic metastasis in a single organ or the regional lymph node. So you can see the tumor is here in the left lung, and there is a single extrathoracic metastasis in the liver, or there can be a single metastasis in the non-regional lymph node. Sorry. Now, M1C has M1C1 and M1C2. M1C1 means multiple extrathoracic metastasis in a single organ. So as you can see, the tumor is in left and there are multiple metastases, but only in the liver, nowhere else. I'm sorry. And this is from a patient with multiple extrathoracic metastasis in a single organ, only in the liver. Patient had a left lung mass and only the liver has metastasis. I'm really sorry. Now, M1C2 is basically multiple extrathoraces in multiple organ systems. For example, bone, lymph nodes, liver, adrenals, any organ basically, but presence of multiple metastases. So multiple extrathoracic metastases and involving multiple organs. That's how M1C is divided into 1 and 2. So what changes have we seen in the distant metastasis basically in your M descriptors is that M1C has now been divided into 1 and 2. And we know that M1C1 is multiple extrathoracic metastasis in a single organ system. So you have extrathoracic metastasis, but only in one organ system. There can be multiple metastases present, for example, like I showed in the liver. Now, M1C2 is again multiple extrathoracic metastasis, but multiple organ systems. Again, why has this change occurred? Because of the worst prognosis in the M1C2. So, worse survival, of course. So, multiple extrathoracic metastasis in multiple organ symptoms systems. M1C2 is basically has a worse survival. So, that is how this change, that is the reason why this change has been brought about. Now we know that as we have these T descriptors, N descriptors, and M descriptors, we stage the diseases right from 1A to 4B. So if subsets of the T, N, M, and categories are grouped into certain stages because these patients share similar prognosis. Like I told you, that stage 1A, which is your T1N0M0, has a 5-year survival of almost 82% when diagnosed and treated. And on the other spectrum, the M1C disease, which is the stage 4B, has a 5-year survival of only 7%. So it is very important to stage, and that is why this TNM, understanding the TNM staging is very important. So to conclude, you know that when you have a patient with a mass lesion, it can come on a screening of on a low dose CT scan in high risk patients. It can be an incidental CT finding. You did CT for something else and you find a mass lesion. And of course, your patient can have symptoms. You can have a symptomatic lung cancer patient. Now, chest CT remains the key first line modality. It helps you to evaluate the size, the margins, the density, the presence and absence of nodularity, whether there is any cavitation or not. Suspicious features that we see on radiology for your lung masses are your irregular spiculated borders, thick walled cavities, part solid nodules, persistent ground glass opacities. So diagnostic algorithm involves your CT chest as the first modality. After, of course, you've done your X-ray, then PET CT for staging, and image guided biopsy or bronchoscopy, and of course, sending your samples for histopathology and molecular testing. Now, TNM classification, the 9th edition, like I said, is very important for staging, for deciding treatment, as well as for prognostication. The tumor is seen on thin slice CT, which defines the invasive size, visceral, pleural, adjacent lobe, chest wall invasions. Nodes are better seen and more accurately identified on PET CT. It has a higher negative predictive value, and you should PET CT. It also helps you to distinguish between N1, N2, AB, and N3 disease. CT is generally unreliable for your nodes. Metastasis is best done with PET CT and best detected with PET CT and MRI to detect the distant disease. And it stratifies M1A, M1B, and M1C disease. Imaging is essential. It defines the extent. It helps you to guide you to where to take the biopsy from, and it avoids unnecessary invasive procedures. Now, management is stage driven. Early stage, which is stage 1A up to 2B, surgery with or without adjuvant therapy, locally advanced disease, multimodal management, chemoradiation. Patient may be a candidate for surgery, may not be. Advanced, that is stage 4, you have systemic targeted immunotherapy or palliation depending upon the patient's presentation. And stage 1A has a 5-year survival of almost 82%, and stage 4B has a survival of as low as 7%. Now, subsolid and ground glass lesions require careful imaging follow-up, and solid component dictates the T category. Overall, imaging is the cornerstone for lung cancer. It helps you to detect the cancer early, helps you to accurately do the TNM staging, guides biopsy and therapy decisions, monitoring treatment, response and progression, and the overall outcome of your patient. Thank you.